So, a very good evening, one and all, uh, to my fellow peers, my seniors, my juniors, and to all our medical colleagues out here. As you all know, ventricular arrhythmias are often the unwelcome guests in clinical practice, often being ominous, egregious, having very bad clinical outcomes, and also being one of the important causes of mortality. While we often discuss through all our podiums optimizing heart failure management, optimizing the management of diabetes, we often discuss a lot of respiratory medicine with you, optimizing management of COPD and asthma. But one of those hidden entities which are not discussed are arrhythmias. To dissect the management of ventricular arrhythmias and optimize therapy for arrhythmias, we have some of the best experts in the country who can brainstorm and give us their views and their overall approach to the management of the same. I have the honor of introducing our esteemed speakers. We have Dr. Vihang Shah and Dr. PC Mondal. Dr. Vihang Shah, who's consultant cardiac electrophysiologist at Pranayam Lung and Heart Institute, Vadodara, and Dr. PC Mondal, who's consultant cardiologist at Apollo Hospitals in Kolkata. Next. So we have Dr. Vihang Shah, who's a highly trained cardiologist and electrophysiologist with expertise in advanced cardiac rhythm management and interventional cardiology. As we discussed some time back, he's the consultant cardiac electrophysiologist at Pranayam Lung and Heart Institute, Vadodara. Having completed his fellowship in electrophysiology at Care Hospital and gaining expertise in cardiac arrhythmia management, he's been prolific across in the field, as well as also serving as an active member of prestigious professional bodies, including the CSI, the Indian Heart Rhythm Society, and the European Heart Rhythm Society. His special clinical interests include SVT management, supraventricular and ventricular tachycardia management, heart failure, CRT implantation, as well as advanced pacing techniques. Next. We also have Professor Dr. PC Mondal, who's consultant cardiologist at Apollo Hospitals, Kolkata. And Sir has over 96 publications in national as well as international journals to his credit, currently working as the senior interventional cardiologist and head of the department at Apollo Multispeciality Hospital, Kolkata. And he's also the director of Apollo Heart Institute. He's received numerous awards in his illustrious career. Next. I now hand over the session to our first speaker, Professor Dr. Vihang Shah, sir. Over to you, sir.
Hi. Am I visible?
You are, sir. You are, sir.
Okay. Share the screen. Can you see my screen?
We can, sir.
Is my screen visible?
Yes.
Hello?
Visible.
Yeah, is my screen visible?
Yes. Vyang, go ahead.
Okay, thank you. Hi, everybody. First of all, I'm very thankful to Macleods for arranging this webinar on such a good topic. And this topic is not something which we don't come in our daily practice and everything. So very thankful to them regarding the same. And for making me come in the stage with sharing the stage with Dr. PC Mondal, sir. Joining East and West, it's such a good thing. So, lastly, very much thank you everybody for joining us for this small academic feast on a Saturday evening. I'll try my best to justify it, and let's see what is the present problem that we are coming across, especially with the better medical facilities improving. Now human being is living more and more, man is living more. And so does that mean that the number of problems are decreasing? No, the problems are increasing. More and more ischemic heart disease, more and more arrhythmias, more and more atrial fibrillation, and more ventricular fibrillations. So that is where we are requirement of some very, very important armamentarium with us to tackle all this. One single one is not going to help us. Like in a war, only guns or tanks is not going to help. We need everything and whatever we have. So let's go ahead with the topic. So Macleods, role of Macleods in a specific subtype, that is refractory ventricular arrhythmias. And most importantly, we will also be sharing with you the insight from the real world evidence. Many of the molecules come into the market after researches, but when it do they really perform well in the market or not? That is the most important. Do they create such a difference in patients or not? That is the most important thing. So the burden of ventricular arrhythmias. So let's see what we are dealing with. So in the first week of acute myocardial infarction, almost there are 12 incidents of ventricular tachycardia. We all know the mortality in this is so high. In fact, 2% of cases also develop the VF, in which the mortality is almost 100%. For a common layman, whenever we talk to the patients or patients relative, we always tell that 33% of the patient are not able to reach the hospital, wherein the CPR or AED makes the biggest difference. But what is the reason behind that? It is this VT and nothing else. So these are the most important part. If they reach the hospital, then you will be able to start treatment. But we need some treatment which can be carried forward in the oral form with the patient. Second part is the heart failure patient. Believe me, few of the biggest comorbidities or epidemics, which I would be talking, which are coming ahead in the next future. One of them common is like we talk about adolescent obesity. One of the similar one which the cardiac related is the heart failure patient. More and more people are living. Now we have such an advanced heart failure medicine. We have ARNI with us. We have CRTs with us. We have everything, whatever we just want to leave, make the patient live. We have transplant, we have LVADs and everything. But does this heart failure patient, it gives a smooth life? Just look at the percentage of non-sustainability. Most importantly, are this heart failure patient, recurrent heart failure patient, are they advised for routine halter over the time when they have giddiness or syncope? No, we do not evaluate that. 50 to 60% of the death in heart failure patient is sudden and attributed, often due to VT. A halter with a patient whose ECG is showing PVCs or ventricular couplets or a different morphology of PVC should always be suggested for a 2 to 3 days halter to pick up those hidden NSVTs and advise for appropriate treatment. This life-threatening ventricular arrhythmias, including VT and ventricular fibrillation, are the most important responsible for sudden death. Their prevalence are increasing more and more. They contribute to almost 3 lakh to 4 lakh death annually. Patient with ischemic heart disease and cardiomyopathy have a 5 to 10% lifetime risk of developing sustained. The maximum prevalence, mind you, is among the general population, but who has the highest risk is the one with the ischemic heart disease or the cardiomyopathy. Understand this point very much. So what are the major risk factors? So the coronary artery disease, myocardial infarction, left ventricular dysfunction, and structural heart disease. Genetic predisposition of channelopathies. When I started my practice as an electrophysiologist, and even now I'm so much surprised, is still till date, so many of the pediatricians in our country do not have an ECG machine in their OPD. Why does a child cannot undergo an ECG? I am still surprised for that. Impact on the healthcare system. There's increased hospitalization due to the ICD shock, recurrent arrhythmias, and the need for repeated ablation procedures. Still, there are a lot of government is coming up. The medical cashless services are also upgrading their procedures and the details, the technology, but many of the things is still unavailable and unknown to the government, as well as the medical policies and everything. Repeated ablation, which are done outside India, are still not available in India. It causes substantial economic burden due to long-term antiarrhythmic device management, and the recurrent hospitalization. So, what is the basic fundamental electrophysiological mechanisms? So, ventricular arrhythmia, they are the most important, a major cause of morbidity and the mortality. This is despite the best antiarrhythmic therapy that you give. The three electrophysiological drivers for the ventricular arrhythmias overall is automaticity, triggered mechanisms, and the re-entry. Mind you, in the SCAR VTs, that is the most common ischemic heart disease patient, the most common one is a re-entrant circuit, and if it's been appropriate treated and early catheter ablation gives a good treatment for that. But is that the end of it? I'm sure we will come across this answer soon. So all ventricular arrhythmia fundamentally arise from one of the three mechanisms. So automaticity, in which there is enhanced or abnormal phase 4 depolarization due to increased extracellular potassium, that is, which is caused by the ischemia. The most common is his Purkinje system or the ventricular myocardium. Then there is EADs, that is early after depolarization, which occurs in the late phase 2 or early phase 3. This causes action potential prolongation due to the increase in late sodium and calcium or decrease in potassium current. Basically, it causes prolongation of the QT, thereby it causes R on T phenomena, and thereafter it causes a VT. Then there are DADs, that is one of the classical example is digoxin toxicity, in which there occurs calcium overload, causing sodium calcium exchange abnormality in sodium calcium exchange current. It occurs after full repolarization. The diversity, the VTs can occur from throughout the ventricles, that is the anterior and posterior fascicular VT. Many of the time, fascicular VT, which occurs in a young chap like 35 or 40 years with a completely normal heart, normal cardiac MRI, normal angiography, normal PET scan. Sorry. They are very easily treatable, very successfully treatable by catheter ablation. They are due to a re-entry within the left Purkinje fascicles. In the P1 diastolic Purkinje potential, it precedes the QRS. So we target the diastolic Purkinje potential, and we have very good successful. Most importantly, they are very much treatable medically by verapamil or diltiazem. That's why they are also told as non-dihydropyridine CCB sensitive VTs. Intrafascicular VTs, it is very common. It is a re-entry between anterior and posterior fascicle. They are macro Purkinje loop. They are also re-entry circuit, and they are basically in very common in patients with severe LV dysfunction, like 15 or 25, 20 or 25% EF, and associated with heart failure. Then there is a ventricular fibrillation trigger, short coupled Purkinje PVCs. The most important is the coupling interval between the normal QRS and the first PVCs which is there. This is the first, one of the most common coupling interval which determines the induction of the ventricular fibrillation. The second is also equally important. That is the first PVCs which occurs and the second PVCs. That coupling interval is also very, very important. Coupling interval is the difference between the onset of a QRS, two neighboring QRS, that is a coupling interval. So that is the most important part. In fact, I had a patient who had a recurrent syncope, a lady, young lady of around 35 years, completely normal heart, normal angios, normal cardiac MR, normal PET scan. He had a single PVCs from the Purkinje potential, and it caused initiation of the VF. She underwent a VT ablation, and she's now good after almost, it's been 2 years. So that's why the characteristics of the PVC, when you see in the ECG, is very important. Like all that is fat is not always bad. Like in obesity, we consider that all that is fat is not good. But in PVC, if the PVC is very narrow, then it's not a good feature. So whenever you get a PVC which is quite narrow, you must understand that it is close to the Purkinje potential, and one should be very careful with that. Upper septal VT, these are usually very narrow QRS and they mimic SVT. They are also very well treated by the VT ablations, and they are Purkinje potential guided ablation. Intramural Purkinje muscles junction, it is source causes sourcing mismatch, and that is what is source sink mismatch is when the electrical potential it goes from the Purkinje and enters into the ventricular muscle. At that point of time, at that juncture, it causes mismatch, and that is why it causes a delayed movement, and it is a reason for the arrhythmia. So it's like in the re-entry, it causes a re-entry. Denetworking of the VF suppression, that is substrate modification of the Purkinje aberration, elimination of the late Purkinje potential, that is mid diastolic potential, and the strategy of refractory VF. So after a small theory of the VT, the most important that we people are interested is how to manage. Now we are not going to every time, like I have a scar VT ischemic patient with EF of 35. I don't want to go too much into what is the most important thing to manage, how to manage. The most important criteria is the hemodynamic stability. If the patient is unstable, don't give a single second of thought. The only and the best treatment is shock, shock, and shock. Pick up the paddles, put at the place, shock it. Don't worry about it. Many of the place, when I started, one of the more important thing which I observed, especially while treating of atrial fibrillation, is when we tell about the shock to the patients or the relatives, they get afraid. No, my friend. This is the one place where if you treat it, you will be saving the patient. Now it's a stable VT. You have all the time in the world. Take out a good 12 lead ECG. Before treating a conscious patient with an ongoing VT, please take a 12 lead proper ECG with one rhythm strip. If you miss this, you are going to miss a lot of things. Consider disease specific VT. A patient with fascicular VT and EF of 55-60 normal heart with a fascicular VT doesn't need to undergo an AICD implantation. The line of treatment is a medical management or a catheter ablation. Yes, so it's a cardioversion. Then structural heart disease, if it's present, procainamide is a good option. Cardioversion, that is a synchronized cardioversion, amiodarone, sotalol. VT terminates, no, then you can plan for cardioversion. VT terminates, no, then if it's a VT storm or severe thing, sedation, anesthesia, reassess. If terminates, assess the therapy and everything. Many of the time, one of the commonest cause of initiation reason for development of VT is heart failure. Do not forget to evaluate for a heart failure patient, especially with patients with EF of less than 35%. NT-proBNP is one of the very, very, very important tests which helps you to diagnose subclinical heart failure. And that is where the treatment with ARNI and SGLT2 inhibitors gives you a big, big difference. Then if it's not a structural heart disease, like I told, typical ECG morphology, verapamil sensitive VTs, outflow tracks VT, RVOT VTs, LVOT VT, advice for ablation, and they are good to run. Now, the subset which is the most common is the ischemic heart disease patient. ICDs with VT and VF. Patient is already underwent an ICD implantation and has a recurrent VT. Look at the morphology. Try to get an ECG in the 12 lead. If not, try to assess the ICD. Do an interrogation of ICD. It will give you a far-field QRS morphology. That morphology is very important. Look whether it's a sustained morphology VT. Is the cycle length same? Sometimes there is a pleomorphic VT. That is, there are 2 or 3 different points from which it is occurred, but they are coming in every cycle. So this morphology of the QRS are different to each other, but if they are getting repeated every second, right? So there is a pleomorphic VT. So they are also very well treated by catheter ablation, and amiodarone sotalol is a good option. If arrhythmia is not controlled, VT storm, catheter ablation is option. We have also sympathectomy is a good option. Non-ischemic cardiomyopathy, catheter ablation is a class 2A indication. Polymorphic VT. Most of the time when the patient is having polymorphic VT, remember there is some reversible factor. There have been patients who has one single VT and they are being given Amiodarone, left, right, and center, and because of those Amiodarone and associated fluoroquinolones and associated omeprazole, the QT has prolonged to 600. Now, the primary problem has already been taken care of way behind, but now patient is persistently having VTs. Patient has underwent, and this is a real example I'm talking, and patient was referred to me before that she had already got 15 shocks at that hospital and on way another 10 hospital during the transportation. When she reached, I was just talking to her. I saw the ECG. She developed a VT. I just observed, did nothing. Believe me, she was conscious. Why to shock a patient who is talking to you? She had developed prolonged QT, and that is where the most important is taking out a 12-lead ECG. Discontinue the offending medication, correct the electrolytes. You have it, boss. You don't need to go any aggressively. You don't need to have those ablations and those all things. Ischemia. Getting a troponin after giving a shock is the most foolish thing that we can do. Immediately when a patient comes to you and you are seeing VT, and if you have time, the patient is conscious, patient is hemodynamically stable, please take blood samples for troponin. Once you shock, it is bound to come positive. You never know that simple coronary arteries can give you a big difference, revascularization. No reversible cause, Amiodarone, beta blockers, Zylocard, arrhythmia not controlled, PVC triggers, catheter ablation, and autonomic modulation. That is sympathectomy, which I was talking to you. So why does this conventional antiarrhythmics fail in refractory ventricular arrhythmias? The substrate complexity exceeds the ion channel modulation. There are persistent trigger mechanisms like Purkinje-mediated PVCs, calcium-driven DADs, and short-coupled PVCs. As I told, the short-coupled PVC, not only the first PVC is important, but the second PVC is also equally important. That's why sometimes you can attach pads with a defibrillator to the patient, and whenever if you take a continuous sprint for that, you may record those things, and it may help in a very good treatment for that. Dynamic physiological stats, sympathetic tone, metabolic acidosis, structural remodeling, and everything. Pharmacological limitations, reverse use dependence, so like sotalol, QT prolongation, and proarrhythmias, negative inotropic limits dose escalation. Like one of the biggest problem with Amiodarone beta blockers, they are also AV nodal blocking agent. We cannot go beyond a certain stage in which the heart rate goes below 50 and then develops AV blockage. So what to do? Then many of the times we put in dual chamber AICD and then we give Amiodarone. Why? Do we have any option? Do we have any answer? Do we have any substitute for these problems? Let's see. Alter drug metabolism in low output states. So that is where this new champion has come into the place, that brother, there are some problems that you are facing. I try to solve. What is the mechanism for its suppression of the ventricular arrhythmia? So their clinic guideline-based recommendation as symptomatic non-sustained ventricular arrhythmias on adequately dosed beta blockade, or non-dihydropiridine CCB, that is verapamil and diltiazem, or other antiarrhythmics, amiodarone, flecainide, Macleods. Structural heart disease with sustained monomorphic VT, specific treatment for ventricular arrhythmias with antiarrhythmic drugs. And Mexiletine is specifically indicated in long QT3 syndrome. CHRS have suggested use of Mexiletine or dofetilide to be used in structural heart disease and refractive VTVF, which are not candidates, or in whom therapy with sotalol, amiodarone, or catheter ablation has failed. Right? In a country like India, catheter ablation is still a very expensive therapy, and patient going repeated catheter ablation is still not possible in the near future at least. And that is where once patient undergoes a catheter ablation, we need something that can give us that advantaged for the VT suppression, that confidence of the VT suppression. So, role of late sodium current modulation in ventricular arrhythmia. So it's a sodium channel blockade, class 1B action. It blocks open and inactivated fast sodium channels. It slows phase 0 upstroke, ventricular excitability, rapid unbinding kinetics, that is, it is use dependent. As the dose increases, it has a positive effect. And the most important for which we have a clinical use, that it has minimal effect on your normal heart rate. Mexiletine is like you give and forgot. You only see whether patient is developing ventricular arrhythmias. That's the best part of it. You are not worried about bradycardia. You are not worried about AV block. And it enhances the block at the faster rate. That means that the patient whose basal heart rate, like 100 or 110 heart rate, it acts even more, right? Late sodium calcium inhibition, that is reduces pathological sodium influx, shortens action potential duration. So that is why sometimes if you see you have started patient with amiodarone and patient is continuing, but you see patient now developing prolonged QT and TDP. So that is where you can shift that patient to Macleods and helps you to take care of that. It decreases intracellular calcium overload and suppresses triggered activity. So adjunct pharmacotherapy with incomplete VT ablation. See, many of the times whenever I put an AICD or when I advise a patient for the AF ablation or VT ablation, so one of the most important and common question faced by me is, sir, इसके बाद दवाइयाँ तो बंद हो जाएगी? No, boss. We need to make it very, very clear to the patients and the relatives that this is a war. The ventricular arrhythmias is a war, and we don't just go in a war with, okay, today I'll fight with guns or tomorrow I'll fight with only tanks. It's the whole armamentarium which you are going to take it. So as per the patient's requirement, you try give medical management, ICD implantation, and ablation. Okay, but the residual scar channels, they are sometimes are very deep, especially in the IVS, intravalvular septum, especially in hypertrophic cardiomyopathy. They are so deep that you may even require bipolar ablation. There are position Purkinje and the trigger activities. And especially in the patient with EF of 15-20%, how many big scars are there? Recurrence despite apparent substrate modification. That is where the role of adjunct therapy is most important. It suppresses residual sodium mediated triggers. It reduces VT recurrence and electrical storm burdens. Many decreases ICD shock and complement substrate-based ablation strategy. Clinical integration. Mexiletine as a sodium channel blockers reduces abnormal depolarization by stabilizing myocardial excitability. Studies have shown that in therapy-resistant patients, not only routine, but therapy-resistant, more than 50% reduction in the ventricular tachycardia is there, achieved in 64, which is a very good percent in evaluable cohorts, highlighting its role. Particularly useful is in the long QT3, where QT shortening was consistently observed, mitigating after depolarization driven arrhythmias. All studies reporting QTC showed QTC shortening, that is 90 patient, relatively of more than 15%. Purkinje triggered ventricular arrhythmias, Purkinje fibers related arrhythmias often resist conventional therapy. Yes, till now till the presence of Mexiletine, this other medical management was not very helpful. Mexiletine prolongs cycle length and reduces the inducibility. EP studies have shown non-inducibility in VT in 30% of the patient and VF in 65% after Mexiletine administration. By increasing the cycle length, almost more than 15% in 55% of studies, Mexiletine dampens Purkinje trigger. Long-term efficacy. Now, like I told, this is a war and we want everything. Amiodarone is one of the, it's like Brahmastra, and it's used left, right, and center. It's used in tier 1 city, tier 2 city, tier 3 city. It's used in the biggest of hospital with 1000 bed, and it's used in 50 bedded hospital or 25 bedded hospital. It's used by the general practitioner and physicians and the cardiologists and electrophysiologists. It's the best, one of the best drugs that we have come across. But man is living more. And with this more and more living are coming more and more problems. So even despite giving Amiodarone, do we have any advantage? So that is where we add this brother to him, and it's like Ecoric 11, and look at the difference. VTMVF episode has drastically decreased, and the p-value is less than 0.05 in all. The total shock has decreased and total ATP has also decreased. Now, at the end of this, some 20 minutes, a lot of theory, but does that make a difference in the practice? Let's see that. Macleods as a standalone antiarrhythmic agent for electrical storm, maintenance dose of 200 milligram and follow-up of almost 1 year. Then 25 patients are taken. Long-term efficacy of Macleods. Look at the VTVF episodes. It's like from 25 to 1, right? Total shock, 0. And total ATP requirement is from 25 to. Just imagine, forget about the shock, even the antitachycardia pacing, which even the patient doesn't know, has significantly decreased, and these all are significant. Less than p-value is less than 0.05. The survival, the Macleods is such a good survival, that is adding Macleods has no significant difference in QRS complex, that is, doesn't cause broadening of the QRS, which is a typical of class 1C drug, that is like flecainide or propafenone. Then the QTC interval, that is the sotalol, amiodarone, which is the class 3 drugs, and the PR interval, because of the beta blockade effect, that is a, excuse me, class 2 drugs, that is the beta blockers, which is also present in amiodarone. Macleods may be effective and safe not only in the patient without ICD but also with the ICD. Macleods in refractory electrical storm, that is a high-risk population, patient with recurrent VT-VF, standard antiarrhythmic therapy. ICD patients experiencing frequent VT shock. How many of our patient ICD does undergo regular ICD interrogation? Many of the time, because of the very good treatment by the ICD of ATP, we do not realize that patient has already developed a VT storm, but because of the ATP given by the ICD, patient has never realized. That's such a good treatment. But are we doing a good practice in not interrogating the ICD of the patient? Because this VT storm can be very well managed by these drugs. Mechanistic benefits in the electrical storm: shortens action potential duration and stabilizes the sodium channel, reduces VT recurrence when used adjunctively with amiodarone, as I told, Ecoric 11, demonstrates significant ICD shock reduction. See, an AICD, it's a very expensive device. No doubt it's a life-saving device, but it's a damn expensive device. And the battery life of ICD, it doesn't depend on the ATP, it depends on the shock. And if the patient is going to receive multiple shocks, the battery is going to come down from 7 to 8 years to almost 3 or 4 years. Key predictives of success is combination with amiodarone in patients with recurrent VT, stable renal and hepatic functions, and absence of severe conduction abnormality, as I just discussed in some time back. Macleods for recurrent ventricular arrhythmias in adult patients with structural heart disease and ICD. So 4 studies, 86 patients, reduced ICD therapy when catheter ablation was unsuccessful or contraindicated. Now, catheter ablation has evolved in last 10 to 15 years, a very good treatment, but there also where catheter ablation has been unsuccessful or unsuitable, Macleods has made that difference. Macleods, it reduces serious ventricular arrhythmias post-MI. As I told 1 in 3 in 10 patient doesn't even reach the hospital. Now a patient has come with you with an anterior wall MI, ST elevation MI, anterior wall MI, you implant you save the patient, and you do patient underwent an LED stenting. But at that point of time, patient had developed VT. That's always the back of a mind. What do you do now? Because if you are not going to give him some prophylactic treatment for this ventricular arrhythmia, there is a good amount of chances he may land up in a sudden cardiac death 10 days later. And the biggest question that you face is, sir, you had done such a good treatment. My relative had walked out of your hospital. What happened? What went wrong? And you and me knows that what the problem he can have. But that is where this is the most important difference that we need to create, that for a short time of Macleods will make a big difference. And here also it has significantly proven. Second thing, many of the time when the patient has develop a VT during the ischemia, xylocaine or lignocaine is one of the best medicine. But what is the oral analog? Are you going to give him IV lignocaine for next 6 months? That is where Macleods is the oral analog of lignocaine. Macleods for the ventricular arrhythmias in patient with chronic coronary syndrome. Analyzed 34 patient and treatment was given for almost 26 months. Enrolled unsuccessful non-feasible catheter ablation and ineffective contraindicated beta blocker or amiodarone. Look at this. Macleods associated with reduction of ventricular arrhythmias, ICD intervention, and comparison with match time period without therapy. The VT-VF episodes have decreased. The number of VT-VF episode as well as the patient intervention has decreased, but it may not be significant. But these two parameters, that is VT-VF episodes as well as the ICD intervention, both has decreased. ICD intervention has almost been half. So I'll end up with a small case study. The routine IHD and ICD patient you must be coming across very commonly, but this is like typical example of a long QT syndrome. Adjunct therapy for refractory VT, 40-year-old woman, 4 syncopal episode, QTC of 580, multifocal PVCs, non-sustained VT, T-wave notching in lead 2, V3 and V4. Type 2 long QT syndrome was diagnosed and ICD implantation was done. Metoprolol tartrate, it's a good medicine, but still patient had ICD shock, Holter, and since the patient was given ICD, this PVC burden we are able to easily know in the ICD interrogation if we do it regularly every 6 months. 33, almost 1 in 3rd heartbeat is a PVC. That is where the Macleods came into the picture. Additional therapy was potassium supplementation and monitoring was done. Outcomes. Look at the burden. It decreased from 15.8% to 1%. QTC also shortened to 452 millisecond. T-wave notching resolved. Long-term follow-up after 3.2 years. No syncope, no VT, no ICD intervention. Sustained efficacy and safety. So Macleods basically normalized QTC and suppresses refractory arrhythmias in long QT. It's a non-invasive alternative and supports early adjunctive use in high-risk long QT. Thank you very much. And I'm open to question, but I think with the paucity of time, we'll hand over to Sir.
Sir, we'll have the session by Sir first, and then
Yes,
we'll have
exactly.
questions. Yes.
Thank you.
Thank you, sir. We now hand over to our esteemed speaker, Professor P.C. Mondal, sir. Sir, over to you.
Am I visible?
Yes,
Slides
sir.
are visible now?
Yes, sir.
Okay. Good evening, everyone. And thank you, Dr. Bia, for a nice presentation. And I am going to present on this molecule again. And this molecule is not new. Basically, it is from 1960s. And Boehringer Ingelheim actually introduced this molecule in 1967, before the birth of me or even. In 1973, there was a study done by Tabot et al. Regarding its efficacy in suppressing ventricular arrhythmia, including PVCs and non-sustained and sustained ventricular tachycardias. But after that, with the introduction of catheter ablation, class 3 antiarrhythmic drugs like sotalol and amiodarone and newer beta blockers, its use has got reduced. And in 2008, it was actually withdrawn from market in Europe and reintroduced in 2018 again in Europe. not for cardiac indication, but for neurological indications like non-dystrophic myotonia and also for chronic pain syndrome. It is also used by anesthetists, those who are running pain clinic. But for cardiac use, it resurges again because the substrate, as Dr. Young has told, that with increasing incidence of coronary artery disease and also that obesity and obesity-related cardiac diseases, arrhythmic death is increasing. And that even after ICD, there may be some fearful clinical scenarios like VT storm or recurrent shocks given by ICD machines. These are very fearful experience to the patient. And in those scenarios, it has got some use. And recurrent ventricular tachycardia in patients with structural heart disease. It is going out from my side. I am sharing again, just stopping my share and going again. Yes.
It's visible, sir.
Yes. Now, whenever I am trying to put off the videos that is there, it is going out.
Mhm.
On the right upper corner, I am seeing all of you. I cannot remove that actually.
So,
Otherwise, some of the part of the slides are hidden.
sir, if you permit us,
Yes, yes.
Mr. Vinayak, if you can quickly just help sir, if you have sir's slides with you, you could probably share it from your end.
No,
Sir,
no, no,
would
no.
that be fine?
I have modified a bit because I have
Modified?
to
Okay,
go
sir.
with it.
Okay, sir. Okay, sir.
There is no problem from my side. I think you are not. You are seeing the full screen of.
We are seeing the
You
full
are-
screen, sir. We are
Okay,
seeing the
okay,
full
okay.
screen.
There is no problem then. And there is too much improvement in catheter ablation also, and ICT machines, even dual chamber pro MRI implantable ICDs, subcutaneous ICDs are there. And also to tide over the post-impact phase, there is a wearable ICDs. But technology brings some problem inherent to it, but it is solving. ICDs are solving the problem of sudden cardiac death, but there will be some inherent problem because there may be some residual risks of having recurrent arrhythmia and recurrent shocks. And catheter ablation, if you see some data in 2013 in compared to 2022, there is success rate has gone up too much with particularly with 3D RFA, three-dimensional this mapping and ablation. And catheter ablation is the preferred therapy in cases of repeated ICD intervention. And catheter ablation may be unavailable at the time of arrhythmia. Suppose a patient has landed up with a recurrent shocks and there is a VT storm going on in the midnight. That is not the time for catheter ablation and may not be feasible in a situation, a scenario where this catheter ablation is not available. And sometimes both catheter ablation and amiodarone are unsuccessful or contraindicated. Suppose the patient is having too much of bradycardia. Patient is having bifascicular heart block or trifascicular heart block. Amiodarone cannot be introduced. In that scenario, clinician must choose between treatment strategies not supported by solid evidence because Mexiletine has got no solid evidence to have any class 2A or class 1 indication. What Dr. Bihang has shown regarding the stepwise approach in ischemic and non-ischemic VTs, including post-ICD VTs management, there was no class 1 indication for these drugs. And we have to go for some other antiarrhythmic drugs or unconventional ablation technique like bipolar or alcohol ablations. Usually I prefer very much if there is a VT storm is going on, with introduction of suppose Mexiletine, it is not getting stopped, and particularly old age fellow, cardiac sympathetic denervation is a temporary, and sometimes after giving a temporary block, if it is successful, we can go with the sympathetic radiofrequency ablation. And Macleods is a class 1B antiarrhythmic drug, sometimes described as an oral form of lidocaine, what Dr. Byang has already told you. And European and North American guidelines indicate intravenous Macleods as a treatment option for acute suppression of BT and oral Macleods in chronic therapy for type 3 long QT syndrome, particularly SCN5A mutation. But there is too much of overlap in the genetic mutation in type 3 and also effective in type 2, some type 2, which is potassium dependent. These long QT syndromes are also a chronic user of this Macleods, which shortens effectively the QT intervals, and there is a clinical support to this. And VT recurrence and its association with mortality is already told. Recurrent VT is strongly associated with higher mortality and hospitalization. And MADID CRT trial data shows 1 to 3 VT episodes increases mortality risk by 84%. And more than 4 VT episodes increases the 6-fold increase in mortality. That means if there is a recurrence of VT, even after ICD implantation, chance of death will go up. And ICD shock burden and psychological impact. It is a fearful experience. More than 2 shocks, there is a 3 times higher mortality, increased heart failure hospitalizations, because each shock will cause some of the myocardial cells to go into a state of inactivity. That means they will be in a state of no contraction. And psychological impact will be anxiety. Patient will become more anxious. Suppose in the midnight he is getting 2 shocks. There will be too much of anxiety. And with repeated shock, we'll think of that my therapy is not at all useful. I am getting repeated shock. That means I am going down. So there is a chance of psychiatric disorder and also depression. Anticipatory shock anxiety. I'll get shock like this. And there may be a phantom shock. Patient is not getting at all shock, but he's telling I am feeling something. It is like a shock. And fear of activity and anxiety, that means quality of life will go down. An impact of recurrent VT on functional capacity and daily living. Pain and distress, ICD shocks for recurrent VT causes physical discomfort and psychological stress. Fear and avoidance, patients often restrict activity or daily tasks to avoid potential shocks. And functional decline, these behaviors gradually reduce capacity and quality of life. And there are 2-3 the data, published data, that psychological impact is too much and quality of life go down very quickly. And there is a thought behavior change, and anxiety spectrum is also towards stress disorders. And shock continuum has got some neurological effect also. There will be too much of adrenergic drive, and VT may go increase also. Mexiletine in the management of recurrent ventricular arrhythmias, the pathophysiology is already been partially told. It's a class 1B antiarrhythmic similar to lidocaine, act as a sodium channel blocker, reducing the phase 0, that means rapid upstroke of the depolarization. That means there will be curve will shifted towards the right and shortens the action potential duration, but minimally lowering the effective refractory period. And regarding its some pharmacokinetic activity, it is absorbed orally, achieving a high bioavailability of approximately 90%. And fast pass metabolism is much less, and it is less than 10%. And peak plasma concentrations are rapidly attained within 2 to 3 hours after administration. And usually within 2 to 3 days, it's got a steady state plasma level because tissue distribution is also high. But there is a bit difference. If we give IV, the tissue uptake is more. And in oral, tissue uptake is a bit slow. And steady state got achieved within 2 to 3 days. And volume of distribution ranges from 5 to 7 liter per kg, indicating significant extravascular penetration, like class 3 amiodarone. Moderate plasma protein binding, primarily to albumin, with 50 to 60% of the drug is albumin bound. And mechanism of action structurally similar to lidocaine, often referred to as oral lidocaine. Like lidocaine, inhibits the inward sodium current particularly early, but it has got some effect on this late sodium channel also. That means phase 0 and phase 1 both are a bit affected. And thus rate of rise of action potential in the phase 0 is reduced. Effective refractory period is reduced. Reduced effective refractory period is of lesser magnitude than the decrease in the action potential duration. That means there will be a ratio will increase. That means effective refractory period with respect to action potential duration, the ratio will increase. And that is the cause of this shortening of the QT also. And antiarrhythmic properties are based on a blockade of fast channel. By reduction of phase 0 maximal upstroke velocity of the Macleods increases the ratio of effective refractory period. But Macleods has got little effect on cardiac intrinsic conduction system. That is its most favorable effect. And extrapolating this three effects, that means no action on or very little effect on cardiac intrinsic conduction system, minimal negative inotropic effect, and does not prolong QT interval. These three are the good effect of Mexiletine, that is bringing it back to clinical scenario. Otherwise, in 1960s, it was introduced, got suppressed, withdrawn from European market, but getting reintroduced again. And introduction is because of this with a specific clinical substrate, because substrate of post-ICD patient, number of ICD patient is not less now worldwide. Even in third world countries like India, our number of patients in follow-up or ICD is too much. If I extrapolate my data, I think I usually implant at least more than 50 to 60 ICDs in a year. So in last 10, 20 years, if they survive, the number is voluminous. So this chance of having this kind of VT storm or recurrent shock by these ICDs patients, at least 1 or 2 in a month. So from that point, use of this drug, Mexiletine, is getting increased. And some of the MI patients who are developing VT after MI, we are giving Xylocard, but how long? And chances of neurological side effect with Xylocard continued infusion is too much. So we can introduce this drug in that scenario also. So with these three good effects, there is no intrinsic conduction system effect, minimal negative inotropic, that is very much important for heart failure patients, and does not prolong QT interval. That is also another boon effect. Sodium channel selectivity and action potential modulation. Action potential effect shortens action potential duration with minimal QT prolongation, and it has got a rapid binding and rapid offset. That is also a good effect. And use dependent blockade, that means greater sodium channel inhibition at higher heart rate, enhancing efficacy in VT and long QT3. Use dependent blockade, that means heart is using more drugs. Use dependent blockade, greater sodium channel blockade at inhibition at higher heart rate. And electrophysiological impact suppresses abnormal automaticity, reduces ventricular ectopy, and mitigates electrical storms, and often combined with amiodarone for refractory VT. This automaticity is getting reduced. That is another effect that some of the channelopathy patients are well treated, particularly long QT2 and long QT3, and also in acquired long QT, particularly with drug toxicities. Patient selection criteria and risk stratifications, ventricular arrhythmias, Mexiletine is primarily used for patients with life-threatening or symptomatic ventricular arrhythmia, especially in those who have failed conventional therapy like a CRTD, already having a AICD, already on beta blocker, already on amiodarone. We can use this drug as an add-on. Isolated use of Mexiletine is not yet recommended except in post-MI, even in those patients if they tolerate beta blocker is the primary drug. Along with that, we can use this Mexiletine. Inherited cardiac conditions, beneficial for long QT type 3, particularly SCN5A mutations. But those who have a polymorphic state, an overlap syndrome of SCN5A mutation, they are also have good effect. And some patients of long QT2 also, they are also benefited by this drug, though they are mediated by potassium channel. Often used alongside amiodarone and beta blocker in refractory cases. That means all three are getting used, amiodarone, beta blocker, and Mexiletine. Here, there will be a counterpoint from electrical point of view. Amiodarone will try to prolong QT, and that will be combated by this Mexiletine, and their effect also will be partially helped by beta blockers. Doses, usual dose to us is 150 milligram 3 times a day, but it can be accelerated up to 1200 milligram. That is the last highest dose. Sometimes we have to give loading dose of 400 milligram and then 150 milligram 3 times a day. And if we want to increase the dose 50 milligram to 100 milligram every 2 to 3 days interval, we should not jump in too much quickly because of chances of neurological side effect is there very early. Late, there may be some cardiac effect also, but chances of having neurological side effect is very early with rapid acceleration of dose. Let the tissue get saturated. That is the time we have to give. Mexiletine in patients with structural versus non-structural heart disease. Actually, the study that was done in 1973 with a structural heart disease, particularly congenital heart disease with some VTs, post-CVG patients with VTs, often used in ischemic cardiomyopathy and in heart failure patients, require cautions used due to co-arrhythmic effect. Best studied for patients with implantable defibrillator to mitigate arrhythmia burden. That is for structural heart disease. And non-structural heart disease, more commonly used in idiopathic ventricular arrhythmia, that is outflow tract tachycardias. This kind of tachycardias are well managed with catheter ablation, particularly 3D ablations. And inherited arrhythmia syndromes typically has a better safety profile due to absence of scar-related conduction disturbances. And Mexiletine's role in combination therapy, combination with amiodarone, that is already been shown by Young. Mexiletine reduces breakthrough VT episodes and help manage recurrent VT or electrical storm in patients unresponsive to amiodarone monotherapy. Combination therapy works much better. Even in that case example they have shown, along with this beta blocker, it was used very well. Amiodarone's prolonged QT interval increases torsion risks. Mexiletine counteracts that excessive after depolarization, prolongation, and enhances cardiac safety. Prekenide or propafenone and enhances antiarrhythmic efficacy in those situations also. And quinidine and disopyramide prevents excessive conduction slowing when used with class 1A agent. Though our experience with this combination is much less. Mexiletine and beta blocker synergistic effect in VT management. Complementary mechanism. Mexiletine, a class 1B sodium channel blocker, reduces excitability in ischemic tissues. It has been told that this Mexiletine efficacy in ischemic versus non-ischemic tissue, it is more efficacious in ischemic tissues. And beta blocker suppresses sympathetic overactivity, reducing triggers for ventricular arrhythmias. Improved VT suppression. Studies suggest combined therapy significantly lowers ventricular tachycardia recurrence, particularly in ischemic cardiomyopathy. Mexiletine enhances beta blocker efficacy in suppressing premature ventricular contractions. and reduction in ICD shocks. This is one of the area where most of my patients who are on Mexiletine is those patients who are getting repeated shocks. Long-term use in my clinical scenarios are those patients who are on ICD but getting repeated shocks. Mexiletine and beta blocker synergy effect in VT management. Indications for refractory VT, primarily used in VT along with amiodarone and beta blocker. Amiodarone sparing strategy, because amiodarone has got so much of tissue effect, particularly thyroid, your eyes, pulmonary fibrosis, liver fibrosis, all are inherent problem with long continued use of amiodarone, and it is dose and duration related. If we can reduce the duration and dose of amiodarone, chances of tissue damage will be less. And another peculiar thing, amiodarone-induced tissue toxicity are, after a point of time, it is not reversible. That means once a patient becoming hypothyroid or hyperthyroid, hypothyroid can reverse, but once hypothyroid, they will be for lifelong hypothyroid. Pulmonary fibrosis, irreversible. Liver fibrosis, irreversible. So efficacy and in reducing VT episodes with Mexiletine is there. So we can spare amiodarone, we can reduce the dose, and we can stop even after if there is no episodes of further VT or BF. But continuing beta blocker and Mexiletine. Clinical data supports its role in reducing VT burden in high CD patients, particularly those with ischemic heart disease. And efficacy in reducing VT episodes also in ICD patients with or without both ischemic and non-ischemic patients. This study is already shown to you effectiveness of, that is a systemic review. Ischemic heart disease patient 3,671 patients. Non-ischemic was 14%, 720 patients. Primary arrhythmia syndromes 144 patients, 3%. Longitudinal diagnosis was 132 out of this primary channelopathy, that is arrhythmia syndromes. Outcome and safety events before initiation of Mexiletine treatment and on Mexiletine. All these studies, though they are not all observational studies, not well controlled, there are some criticism with all these studies. Our efficacy has been proved that patients free from ICD therapy, or that means in the form of shock or anti-tachycardia pacing, is much, much reduced. But in Vanish trial, it has been shown that catheter ablation, particularly in an experienced, dedicated personnel, it has got it more efficacious than this kind of drug therapies. But there will be again a substrate who will be not amenable for ablation. Maybe ablation is not successful. In those areas, this therapy will be really a helpful drug. But this Gao et al. In 2013, in compared to Mugnai in 2021, catheter ablation success rate has gone up. Those young fellows who are recently passed, they are getting trained well for an CRT implantation. We have to travel abroad to learn that. But now presently, most of the centers in India are getting even during DNB course or DM course, they are getting trained to implant an ICD and CRTD. So use of this technology, particularly this RFAs, radiofrequency ablations, the success rate is going up. Even they can come and do this radiofrequency ablation in the midnight. Reduction in cardiac event burden with Mexiletine, it is already proved. VT burden, VF burden, and this PVC burden all will go down. VF occurrence, over 50% reduction in VF events if we treat They are precursors, that means father and forefather, that is VT and PVCs. Integration of Mexiletine in ICD therapy. That means we can mix up antiarrhythmic drug with ICD. That means all the arms, all the structural backbones will be there, like the pillars of heart failure therapy. Though the pillars of heart failure therapy has reduced a sudden cardiac death over last 30 years, and that is because of reverse remodeling and electrical stability of myocardium. But even after that, there is residual risks, and ICD prevents sudden cardiac death, but do not suppress PVC episode or VT episodes. That means ICD is a therapy, but it cannot prevent, leading to a recurrent shocks, increased hospitalization, and reduced quality of life. That means during implantation, patient and relatives should be counseled that it will prevent your sudden occurrence of VT, and it will terminate that VT, but occurrence of VT will not go with this. This is to overcome these VT episodes and prevent sudden death. But prevention of that VT episode will be done by drugs. That can be a combination of beta blocker, amiodarone, and Mexiletine. And that can reduce the recurrent shocks. Quality of life will increase, and hospitalization will be less. And reduced quality of life, that will be counteracted. Frequent ICD therapies are associated with worsening myocardial function, because some of the myocardium, after getting shock, will be in a state of inactivity. That inactivity can be very transient, can be for days, can be for weeks. And it prevents electrical storm. Repeated shock, after few shocks, your ICD may stop giving shockers. That can be a dangerous event. And there is a psychological distress from the patient point of view. Suppose he is sleeping and suddenly gets shocked. Then there will be too much distress, and he will be afraid to go to bed in the next day. And many patients require antiarrhythmic drugs to suppress VT, but conventional options like Amiodarone have long-term toxicity concern, what I have described before. Mexiletine poison in ICD patients. What is the status now? Effective VT suppression by selectively inhibiting sodium channels in ischemic myocardium. Mexiletine helps suppress recurrent VT, reducing both appropriate and inappropriate ICD shocks. QT neutral profile. Unlike class 3 agents, sotalol, dopetylite, amiodarone, Mexiletine does not prolong depolarization, making it a safer option in patients with structural heart disease who are at risk of prostate depointes. Combination therapy with beta blocker or amiodarone, or combination of triple therapy, when used alongside beta blocker, Mexiletine enhances arrhythmia suppression while avoiding excessive bradycardia. Mexiletine as a bridge therapy before catheter ablation. Challenges in managing uncontrolled VT before ablation, electrical storm and hemodynamic instability, awaiting catheter ablation. That in that time, we have to keep the patient alive. In that period also, we can go with oral loading dose or even IV Mexiletine to suppress that VT storm. And we can take the patients for your ablation. As it has got no effect on conduction system, no one will be afraid if the patient is on Mexiletine to go for catheter ablation and episiotomy. Amiodarone, though effective, requires long-term and has got significant systemic side effect, making it unsuitable for all patients. So in selective patients, to tide over the situation, you can use that also, but failure after that is also a problem. Patient on bradycardia, already on borderline QT, already on having some fascicular blocks, amiodarone may be a relative or absolutely contraindicated. Sedation anesthesia risks during emergency ablation in unstable patients underscores the need for polymorphic pharmacologic VT suppression before the procedure. So in that scenario also, Mexiletine will be a choice. Mexiletine as an effective bridge therapy Immediate VT suppression maxillary rapidly reduces VT episodes, providing stability until definitive catheter ablation is performed. Alternative to high-dose amiodarone in patients unable to tolerate amiodarone, Macleods offers an effective QT-neutral antiarrhythmic option. Hemodynamic preservation, unlike other sodium channel blockers like flecainide and propafenone, Macleods has a lower risk of negative inotropic effect, making it safer in patients with reduced ejection fractions. Though there are some case reports where it has been shown that Macleods also can reduce ejection fraction in some subgroup of patients. So Mexiletine versus on PVC suppression, data from historical studies. Some of the studies I have already shown you that it has got a good effect on PVC suppressions, particularly those who are from outflow tract PVCs and also polymorphic premature ventricular contractions and some of the interpolated ventricular ectopics, they can be suppressed. Usual dose for with this PVC suppression is around 600 milligram. And effective suppression has been shown with this only. Dose increment up to 1200 is much less because it can invite toxicity. Oral Mexiletine for ventricular tachycardia, that's a systemic review that has already shown. And addition of Mexiletine led to 40% reduction in number of patients with ventricular arrhythmia recurrence during matched observation period ranging from 8 to 26 months. All these studies I have shown in a sum up slide. There's all these studies, these are done in last 10, 20 years, all shows a favorable effect, but blood concentration of Mexiletine should be monitored. Usual therapeutic dose is 0.75 to 2 nanogram per ml. Mexiletine in long QT syndrome and Bugada syndrome. Mexiletine in long QT, highly effective in long QT type 3, reducing VF by 90% in 98% of patients, consistently shows the shortening of QTC with more than 15% reduction in 27.3% of cases. It is recommended for not for long QT1, but for long QT type 2 and long QT type 3. And arrhythmic version, SCN5A mutation with long QT3 has got the highest effective rate, and they are treated most well with this. There are some areas where Mexiletine can be used in Brugada syndrome also. These are the minimal effect on heart rate and QRS duration, influences ST segment and QRS in Brugada patients. Chances of also death is getting reduced. Mexiletine in patient populations, elderly, no dose adjustment in normal renal function. Chronic liver disease is an area where we need some dose modification. Renal impairment, no dose adjustment is necessary in patients with mild to moderate renal impairment, but need not to be used in creatinine clearance less than 30. Hepatic impairment, caution in mild to moderate hepatic impairment. That means even a mild hepatic impairment can increase your dose, can increase the plasma level. A minimum of 2 weeks between dose adjustment is recommended. Precautionary consideration for Mexiletine use. This is very important. Severe renal or hepatic dysfunction require dose adjustment or alternative therapy. Particularly, if there is a severe liver dysfunction, its use should be very cautious. Chances of acute liver failure reports are there. History of Mexiletine intolerance. Patients with prior adverse reactions such as severe gastrointestinal intolerance or neurotoxicity. There can be neurotoxicity in the form of drowsiness. There may be perioral tremor. There can be an unexplained tremor, dyskinesia. All this can happen. A Bijari kind of neurological syndrome can be a presentation. One of my patients was admitted with this kind of Bijari thing, but it was looking like that lidocaine, after 2 to 3 days of lidocaine, same thing happened with another patient also, because it has got some similarity with that kind of clinical features. So with this, I'm stopping here. Thank you for this opportunity to present or to discuss this new drug. In a new drug means old drug getting resurgence, because if we think of for last 4 or 5 years, it is getting used more by the neurologist for their some of the patients with non-dystrophic myotonia and also for chronic pain syndrome. But our use also, there are subset of patients where you can use it that we have discussed in last 1 hour. So we can take up questions if
Thank you,
there
sir.
are some questions already posted, or we can raise some question by ourselves.
Thank you so much, sir. A very endearing discussion between by both Vihang sir as well as yourself, and quite comprehensive, covering things in a very lucid manner and being very comprehensive in covering the entire thing. Some of the questions that have come have already been covered in your talks, but nevertheless, we would like to very quickly take them. So Dr. Rajat asks, in clinical practice, in real world clinical practice at your end, how has been the safety of Mexiletine?
Safety of Mexiletine is, it is not, first stamp will be, it is not a safe drug. It needs too much of monitoring. Before initiating Mexiletine, you should be clinically very sure that this patient needs Mexiletine, because the acute effect will be on mostly neurological side effect will be the dangerous one, particularly in the form of drowsiness, incoherent talk, perioral tremor, dyskinesia, a bizarre kind of symptom. It looks like acute onset Parkinsonism. Like beforehand, one of my patients looks like, suppose before, after giving regnal injection, some patients develop some dyskinesia. It looks like that this Mexiletine toxicity patients are getting admitted through emergency acutely. They looks like in the same kind of thing. There will be some tremor, bizarreness, talk will be some dysarthria kind of thing. Is they are drowsy, not communicating well, and limbs are moving here and there. So that bizarre symptoms will be there. Regarding gastrointestinal side effects, there can be a indigestion, eructation, acute diarrhea. These are manageable, but neurological side effects are very dangerous. And regarding cardiac side effect, there may be poor arrhythmia, but chances of poor arrhythmia is much less in compared to amiodarone. Amiodarone is more poor arrhythmic than your Mexiletine. But if your choice of patient is all right, you know the how to titrate these drugs, and if you have the facility to measure the blood level, serum level, I think it can be used safely. But the background, what we have described, particularly in my discussion, it was how to titrate the dose, or who are the patients where we should initiate, that I have discussed. So Dr. Rajat, he has asked this, that Dr. Chandan, what are the challenges in managing arrhythmias, in managing heart failure patients on ICD?
ICD. This was so well covered by...
already highlighted those
Absolutely.
areas.
Dr. Vihang has very wonderfully highlighted.
Highlight some point more.
Vihang sir, over to you. So if you can, you have already reiterated that so beautifully in your talk. But once again,
heart failure is one of the biggest upcoming epidemic. Not upcoming, it is already there. And heart failure management is not a single person job. No matter how much specialist, how good you are, clinician or doctor, no, it doesn't take a. At my center, for me, a heart failure patient is managed by a cardiologist, is managed by an electrophysiologist. So I am there for that. Then a dietitian looks into that part. Then a physiotherapy, the cardiac physiotherapist takes into the role. These four are the main. Then you go into the detail of the heart failure management. So suppose it's a non-ischemic cardiomyopathy, you try to evaluate it by an associated cardiac MRI or PET scan, in which case if it turns out to be a granulomatous myocarditis, then a pulmonologist or a rheumatologist, that is TB myocarditis or sarcoidosis comes into the picture, pulmonologist comes into the picture. More and more heart failure patient has an associated acute kidney injury. One of the things which we forget is the acute kidney injury in the heart failure patient is not due to decreased renal blood flow, but it is due to renal blood congestion. 70% of the time, the acute kidney injury is due to the central venous congestion of the renal vein. And that's when we dehydrate the heart failure patient improves. Nephrologist also comes into the picture many of the time, very terminally patients now, if they develop sepsis and everything, an infection specialist, and CRRT is one of the very good modality for a patient of requiring dialysis in a severe heart failure patient with hypertension. So there is a lot of things in heart failure. It's like it's a team management rather than a single practice. An associated treatment of iron deficiency, a proper vaccination of the patient. So those all things is more important. As of, if I say particular with very focus on the arrhythmias part only, and every patient with heart failure with an EF of like less than 35% should undergo a regular ECG and echo evaluation. Should undergo a Holter evaluation with a low threshold if the patient has complaint of giddiness or something like that. Regular ECG is very important because then you can see the progress of QRS widening. Sometimes you can see the development of LBBB. Okay. And most importantly, whenever patient has developed any arrhythmias and everything, prompt treatment should be there and not wait. Like a single PVC or two PVCs should always keep a low threshold for a Holter, which is very underutilized in investigation. In case of arrhythmias and everything, one of the most important reason for the arrhythmias is the underlying heart failure, in which based on the anti-proBNP and everything, patient should be treated and patient recovers very bit. Another thing is like an ICD or CRT regular interrogation should be done, in which you can get thoracic impedance from advanced ICD or CRTs, which can predict the development of heart failure at a very, very early stage. So those all matters. That's how it should be managed. So.
Thank you. And another question has been put up by Dr. Robi. Mexiletine and oral congener to lidocaine. How can this be utilized in practice? Suppose a patient on post-MI patient on VT, we have started, suppose a life has been saved with an DC shock on Gylocard now. But how long we should continue with this Gylocard? So we have to think of some substitute that will be Mexiletine because it is an oral lidocaine. We can introduce Mexiletine, and for next few weeks we can go on with this, and after that we can try to withdraw. If there is no recurrence of these PVCs and other markers, we can stop that also. So in that will be a bridge. And Dr. Shotis has asked, what are the advantages on combining Mexiletine with Amiodarone in practice or as alternative to Amiodarone? In one word, Mexiletine is an amiodarone sparing drug. Mexiletine is a drug where amiodarone cannot be used because of bradyarrhythmia, QTC prolongation, or fascicular blocks or bundle branch blocks. There was patient with an bifascicular block, trifascicular block, left bundle branch block, having bradycardia. They are the candidate where Mexiletine can be used. If a patient is requiring long-term amiodarone in a post-ICD situation, better not to continue with a high dose of amiodarone for long continued time because it will cause a tissue injury that may be irreversible. In those scenarios also, Mexiletine can be used, and it is a Mexiletine sparing effect in that areas.
Sir, I believe those are the end of the audience questions, and all the audience questions were actually repetitive of things that were already covered. Since I think after the first talk got over, a few of the questions came, and those were very well covered by Professor P.C. Mundal, sir. So one quick takeaway, because there are a lot of physicians who are attending this platform too, not just cardiologists. So what takeaways, key responsible takeaways you would want to give for physicians here who do sometimes see ventricular arrhythmias in their clinical practice? When should they refer to a cardiologist? Of course, they would refer most of them to a cardiologist, either ischemic or post-electrolyte disturbance, or because of heart failure or whatever. But what key 4 or 5 clinical takeaways would you want to give to the physicians attending this webinar. Vihang sir, over to you.
So, the most important part is I take it as proper evaluation of the patient, and always have a key for what are the possible complications in a patient with a ischemic heart disease. See, with a patient with a normal heart, usually with a 55 or 60% with a fascicular VT, okay, they are not going to have a sudden cardiac death. The chances are quite less. Ischemic heart disease is a subset where keen interest is very important. So patients, especially with the EF of less than 35, always try to evaluate as early as possible and have a low threshold for getting evaluated for the ventricular arrhythmias and atrial fibrillation, both of them. In case of ventricular arrhythmia, amiodarone itself is also a very safe drug. The chances of developing prolonged QT and hypothyroidism and everything is not like 15, 20, 35%. It is like less than 5% everything. But here you have a drug which is like you can use very safely, uh, uh, keeping in mind the adverse effect and side effect which Prakash sir told, Mondal sir told. So keeping those in the mind, Mexiletine is drug which you can start at a very lower dose also and start titrating up as per the PVCs or VT episodes and everything. Don't wait for the ventricular couplets to get into VT storms and everything. Many of the patients with ICDs are in regular follow-up with the physicians for the diabetes or with nephrologists for the kidneys and everything. Please get this pacemaker and ICDs or CRT. Get regular checked up every 6 months. This is one part where you can pick up during that interrogation the underlying hidden VTs, and an appropriate treatment which can be started at your level makes a big difference.
Thank you, sir. Thank you. If I may, you also said a very wonderful thing about having a low threshold to shock a patient, especially when there is features of chest pain or heart failure. So if you could just reiterate that, we would want that message to go very responsibly to our physicians, if you could.
So in like for a layman, the shock is a very big thing. Believe me, like today only I had an encounter. A patient with a hemodynamically stable VT. I tried Xylocard, I started Amiodarone and everything, beta blocker, but still it was not. So we did a very simple, we sedated the patient. We did a synchronized cardioversion. And that's it. The patient is in sinus rhythm, it's almost 24 hours. All physicians who are handling the ICUs, please be equipped with this simple defibrillator with you. A patient who is hemodynamically stable, you can do a synchronized cardioversion, or who is in serious condition, immediately defibrillator shock should be given. A shock in time saves 9 lives, I would say like that. And it does create. I have in my short professional life, I have given some patient lot of shock, and they are ranges in 30 to 40 shocks. And believe me, they have walked home. So what is an ICD? It is just an implantable shock machine. That's what it is. So keep a very low threshold for this shock if you are suspecting a VT and patient is hemodynamically stable. Even if you do not have any time to get a ECG in a patient, if the hemodynamically unstable, give him a shock. I always remember from my MD medicine, I really respect that madam, and whenever I met her, I remember those things. She told me that I was in the rounds and I told madam I gave shock. So madam asked me, where is the ECG of the patient? Well, I'm sorry, ma'am, patient was collapsing and I did not have time. She was initially showing very angry face, and then she smiled. Okay, if you would have taken ECG, I would have got more angry on you. So that's the point important. Our decision making is the most important thing. That ECG is the most important, but in such few condition, your clinical acumen is more important. Shock the patient, you will have that time to get the ECG.
Thank you, sir. Mondal sir, your key pearls of wisdom.
Actually, what Biang was trying to told our audience there is a areas, some of the railway stations, airport, there is a bystander AEDs, external defibrillators. And basic life support should be trained to those fellows there. I mean, in the airport, railway station, where there is a gathering. That means one shock will save the life. That means unexplained syncope is sometimes that patient is not coming back to sense. That means something is going on inside. For a general people, a shock will be the answer for those clinical scenarios. And for physicians, some of the high risk situations, suppose a 16 years boy or 18 years boy is having syncope and his disease is showing some PVCs. That means he is symptomatic and there are some ECG showing some PVCs only. Most of the time, we check sodium, potassium and thyroid, everything all right, okay, forget about it. But that is not the scenario. Out of 100, one may die in next 5 years. So in those patients also, particularly those who have syncope, family history of sudden death, early age of onset of this kind of symptoms needs evaluation, particularly to long-term Holter monitoring or by electrophysiology, or at least that ECG or PVC should be analyzed by an electrophysiologist. What is the nature of these PVCs? That will tell you if that ECG can capture that PVCs, analysis of this PVC, particularly its timing, interval with the previous normal beat and after normal beat, that relation and its morphology and terminal QRS, all will be analyzed and high risk behavior can be analyzed who is in need for electrophysiology studies and may need ablation also. And this is for those who are healthy young man like this. But for a suppose in risk diabetic, hypertensive, not known ischemic heart disease, having a syncope with an ECG showing some PVCs or Holter showing some non-sustained BT, that will also be evaluated by a cardiologist or electrophysiologist. They should be evaluated fully because their first presentation with ventricular arrhythmia may be a sudden death. So, and they should be evaluated for ischemic heart disease also. Another subset will be an post-MI patient. Post-MI patient, particularly those who are in ICU, Dr. Biang has told that those who are managing ICUs, they should be conversant. On the first day, they should know his ICU or CCU. Where is the defibrillator? How to use it? Where is the electrical point with that, all the beds? He should be acquainted because he will get in 1 minute time. Suppose a bed number 10 is having VT, he should rush and do whatever is needed because otherwise the VT will be terminated, life can be maybe saved, but by that time brain will go. So response time is also very important in a critical care area. And after discharge, if that patient goes to a physician with a curious complaint that I have sudden head turn, I was about to fall, I have to hold something to prevent that fall. That kind of funny symptoms or a frank syncope or ECG showing some QRS broadening, showing some ectopics, that also needs full evaluation with long-term monitoring and if needed by an electrophysiological study. Otherwise, there may be a sudden death in near future. Another group, those who are with non-ischemic cardiomyopathy or ischemic cardiomyopathy, all patients now guideline is the MRI should be done, cardiac MR should be done to identify scar burden and heterogeneity of the scar, particularly the transition zone between the scar and the adjacent area, normal area. Now, scar transition area, those are the areas where from the VT arises. And now, ECG, Holter data, this gadolinium enhanced MRI data can be fed to AI, artificial intelligence, that can calculate the risk of recurrent arrhythmia and death. A prophylactic ICD or a prophylactic drug therapy can be initiated for those people also. So all heart failure patients should be in a state of dryness so that LV-EDP should be minimized. They should be evaluated for risk of sudden death. All heart failure patients should be evaluated for sudden death. And that sudden death prevention needs some clinical input, whether there is any syncope, free syncope, palpitation, and choking of breath during sleep, ECG showing PVCs, there is changes in the broadening of QRS, terminal portion of the QRS are getting flickered, Holter showing PVCs or monomorphic non-sustained BT or sustained BT, and gadolinium MRI showing some scar, and the scar burden is high, and there is a heterogeneous scar in the scar normal tissue transition zone. These are the areas who are at risk of having sudden death. We should prevent that with either by ICD or ICD plus drug or only drug. But that depends on the risk profile. That should be evaluated by a cardiologist, specifically by an electrophysiologist. Otherwise, this death cannot be prevented. Now, because what I have started with this Mexiletine introduced in 1960s. In 1960, this CPR also introduced. CPR was introduced in 1960. How much the death has been changed? Even in hospital cardiac arrest, highest survival, even in developed country, is around 17 to 21%. And that was around 14 to 15% in 1970s and 80s. That is what has been changed after arrest. Change is not there. You have to prevent that arrest. Prevent that arrest. Like whenever I am putting an ICD, I should know how to prevent a recurrent BT storm. Byung is stressing repeatedly that ICD should be evaluated, ICD should be evaluated. What is the idea? We should prevent that BT storm because silent BT storm can going on. ATP is terminating the BT. Myocardial ejection fraction was 30-32. It will go down with time. After repeated this kind of storm, ATP, it will go down to 23-24 like this. Even with all these four pillars of heart failure, drugs, it cannot prevent deterioration of ejection fraction. So VT storms should be prevented. If needed, Mexiletine is the drug for those patients also. That's why it is coming up. Otherwise, after 50, 60 years, why you are rethinking of Mexiletine? Its first study was in 1973. Now we are rethinking that where we should use it. These are the substrate areas where we should use. So this is my message for those for the young, those for the post-MI, those who are having only risk factors, or those who have a DCM in the ischemic form or a non-ischemic form. But for channelopathies, and also hypertrophic cardiomyopathy is recommended now. We should go for whole genome analysis. If the genome is favoring that it is an arrhythmogenic channelopathy, we should manage it. Particularly for long QT3, Brugada, long QT2, Mexiletine is a good drug. We should go for it and prevent the sudden death. Thank you.
Thank you so much, sir. Wow. Dear sirs, it was a very endearing session, and we're very sure that the audience has actually gained a very lot from these discussions. What we genuinely appreciate, Vyang sir as well as Mandal sir, was this was a very stepwise clinical discussion in the slides rather than just discussion of studies, which is something that occurs in some sessions. This was actually very clinical, stepwise, and the audience has also been giving time right at 9:30 on a Saturday, being very attentive, posting their questions regularly. So we're very sure that the audience has had their takeaways and learnings in clinical practice. Dear audience, we also thank each and every one of you actually for taking your time for upskilling yourself and staying abreast with knowledge, and ultimately trying to have takeaways that will ultimately improve your patient care outcomes. Last but not the least, we at Macleods also thank our technical partners from DocMote, for aiding in the very smooth streaming of this webinar. Thank you, Mandal sir, and thank you, VM
Thank
sir.
you. Good night.
And
Good night, sir.
thank you, sir. I am Akil from marketing team. And thank you to Mudal sir and Vyang sir. Sir, in future, we like to be associate with you for the same kind of academic initiative, sir. Please give us opportunity. Sir, once I'm in Calcutta, we like to meet you, sir. Mudal sir especially, and Vyang sir to you also.
Thank you.
Thank you so much, sir, for giving us opportunity, sir. Thank you so much.
Thank you.
Pleasure sharing stage with you, sir.